placing your orders.
60 seconds.
Oh, there we go.
Yep, mic's on.
Mic's on. So mic's good. You know, I think we're getting there, yeah. All right. Good evening, everyone. My name is Nathan Weed, and I am the interim administrator for the Chelan and Douglas Health District. We've gathered here this evening with several local health officials as well as some of our elected officials because of the emergency our community is facing. We're now seeing the highest number of COVID-19 cases that we have seen since the start of this pandemic nearly a year ago. Our health officials with us are here to share the facts of the situation, to give you an honest picture of what we're facing as a community and give you some thoughts on how you can help. Speaking tonight, we will have Dr. Malcolm Butler. Malcolm Butler is our County Health Officer for the Chelan and Douglas Health District. We have Dr. Peter Rutherford next to him. Dr. Rutherford is the CEO of Confluence Health. Next, we'll have Dr. Mabel Bodell, a nephrologist or kidney doctor at Confluence Health. And we will be closing out the evening with one of our county commissioners, Kevin Overbay, who is a Chelan County Commissioner here locally. We're also joined in the audience by many of the mayors from the cities and towns in Chelan and Douglas County. And we're all here to spread our message and show a gathering of support. So I'd like to begin and introduce Dr. Butler. Dr. Butler, would you take it away?
Thank you, Nathan. Hi, everybody. Malcolm Butler. I'm a family physician. I spend most of my time at Columbia Valley Community Health. I'm also the health officer for Chelan and Douglas counties. And first off, I just want to thank all of you for being here this evening, spending this time with us. I also want to extend a special thank you to all of the healthcare professionals who every single day are waking up and strapping on their PPE and running towards this fire. I want to also extend my warmth and understanding to the 500 or so of our neighbors who found out within the last week that their test for COVID came back positive, and for the physical and emotional distress that you all are going through right now. I have some slides for you today. The first slide, as you can see, is our most recent data. I want you to attend to the red print in the lower right. And what you can see is that the incidence currently is at 685 per 100,000 per 14 days. Many of you have probably heard that number before. That is the highest that we have had in Chelan and Douglas County since the beginning of the pandemic. Importantly, also, the 827 cases that we've seen in the last 2 weeks make up 17% of all of the cases we've had since February. So we've had 17% of all the cases in the last 2 weeks. The second slide is a graphic looking at the positives. It's pretty easy to see that first wave, and it's pretty easy to see how steeply the second wave has taken off. In the third slide, you'll see the local incidence, and you will also see the exponential growth that we have been experiencing over the last few weeks. On the fourth slide, this is now data actually for Washington State. And I bring this so that you can see that just like Chelan and Douglas counties, Washington State is now into its third wave. But you'll see at the top of the graph there that arrow that's pointing north. So the Washington State overall is at about 200, 220 per 100,000 per 14 days. We are at 686. We are 3 times higher than the rest of the state. On the 5th slide, this is a somewhat busy graphic, but this is looking at our local hospital capacity and how many COVID patients we have. And this is looking at what we call our catchment area. So this is Confluence Health. This is also Samaritan and Cascade and Leavenworth, Lake Chelan Community Hospital in Chelan, and also, I believe, up in Omak and Brewster. And what you can see, that red line, that's the 10% of the beds available are filled with COVID patients line. And anything above that line, the Department of Health and all of us in healthcare start getting anxious. And you can see that last week anyway, we were above that line. Just now we've dipped below it. The 6th slide is similar, but this is looking at all of the hospital beds in Eastern Washington. And again, you can see that all of the beds, and this is including Spokane and Yakima and other large population centers, that overall we are well above that 10% mark. Slide 7 is looking at the testing that we have done. This again is a little bit busy. I'm not going to take a lot of time to explain it, but what you can see right now circled in red there is that 12% of the tests that we did last week returned positive. What we know is that number needs to be under 2% for us to be feeling comfortable, and it's currently up at 12%. I was speaking with some of my staff in the clinic today, and they were talking about how painful it is now with these rapid tests that we're doing. Previously, they used to walk a family of 3 into the clinic and test them, and they never saw the results because they went home and received their results 3 days later. And now all 3 come back positive. And it's an emotional burden for everybody who's working with this to see the faces of the people who've been told they're positive. On slide 9, this is looking at where these cases have been in the last 2 weeks. And what you can see is that the vast majority of these cases are happening in our big cities. So on the left is Chelan County, and on the right is Douglas County. And you'll see by far and away the majority of the new cases are happening in Wenatchee and East Wenatchee. But then when we move to slide 10, what you can see, and this is actually looking at cases but filtering for the population of that town. So this is what we call our incidence rate. And you can see that when you look at it that way, Leavenworth in Chelan County and Orondo in Douglas County are really our hotspots right now. But you can also see how broadly this is spread out in Chelan County. And I'll read these names in case you can't see them. Kashmir, Dryden, Monitor, Peshastin are all within that red circle that I've put there. Slide 11 is a representation of Hispanic versus non-Hispanic. So on the far left is back in March. The far right is this week. The light blue are Hispanic. The dark blue are non-Hispanic. And this is looking at all of the positives. And what I want you to notice is that for the majority of the pandemic, about 80% of the disease burden has been in the Hispanic population, remembering that only about 31% of our neighbors are Hispanic. And then starting right around the beginning of October, that number dropped significantly to about 50%. So although the Hispanic community is still carrying a disproportionate share of this disease, it's much better than it has been. And I just want to thank everybody who's been involved in making that happen. The last slide I have for you is a look at our mortalities. And I think the first thing I would like to say is I'd like to extend my condolences to all of the spouses and sons and daughters and grandchildren of our neighbors who have died of COVID. I also learned just this afternoon that Chelan and Douglas Health District has reported an additional 6 mortalities today. Those mortalities happened over the last week, but we are reporting today an additional 6 mortalities. What you can see and what the circles here represent are that to date, about 60% of our mortalities have been over the age of 70, but fully 40% have been under the age of 70. So although it is much more common for the elderly to be affected and to not do well, it can also happen to younger people. So those are the ends of my slides, and now I'd like to introduce you to my very good friend, Dr. Peter Rutherford. Peter and I have known each other for the last 25 years, and Peter is currently responsible for taking care of all of us through Confluence Health.
Thanks very much, Malcolm. And I first want to say tonight, thank you very much for the opportunity to speak here this evening, and thanks to those of you who are listening and attending. And to those I want to, in the community who have taken this COVID-19 infection seriously, I want to thank you again. This is clearly something unprecedented, and the impacts to our community's health, its physical, economic, educational, and emotional status are dramatic and will be long-lasting. This is clearly the largest challenge I have ever been involved in my career in healthcare. COVID-19 has now been with us since late February, and we are now, as Malcolm said, at a crux moment. With the recent news of a viable COVID-19 vaccine, a light at the end of the tunnel is visible, but it's in the far distance, and there's a big gap between now and that hope for the future. Tonight, I want to just take a few minutes of your time and give a perspective on where we are now, what I'm worried about, and then finish with an ask of all of us. So where are we now with COVID-19? Well, since February, we've certainly learned a lot about this disease. We've learned how it's spread and that the initial symptoms are much like other viral infections. We have learned that people with diabetes, hypertension, obesity, and older ages are at higher risk, but none of us are guaranteed an easy course of infection. We have learned that 20 to 40% of the people infected are completely or minimally symptomatic and may remain asymptomatic throughout their entire course of their infection or develop symptoms in a couple of days. However, asymptomatic individuals can spread the disease just like those with symptomatic infections. This is relatively unique to COVID-19. Other respiratory infections like common colds and respiratory infections like influenza don't transmit nearly as much from an asymptomatic individual. We've learned that closed areas with reduced ventilation increase the risk of spread. While being outdoors clearly is a very nice way to minimize the risk, it also does not appear that passing somebody in the hallway confers a significant risk. Infection is much more likely after greater than 15 minutes of total exposure in 24 hours to an infected individual at a distance of less than 6 feet. We have learned that there are significant disparities of education, housing, and employment in our region that significantly affect your risk of acquiring the disease and your course. We have learned that an infected individual wearing a mask is 90% less likely to infect those around them than without the mask use. We have learned that wearing a mask likely reduces your risk of infection from someone else by about 20%, and there is some data to suggest that if you get infected while wearing a mask, your risk of a severe outcome is much less. We've learned that personal protective equipment used properly works very well, but the supplies of some PPE components remain in limited supply, and we do need to continue to conserve them where it is safe to do so. We have seen in the hospital an incredibly committed staff that gave all they have physically and emotionally over the last several months to care for these complex COVID patients. It takes about twice as many staff to provide the needed care for a COVID-19 patient than a typical ICU or hospital patient. These staff members are tired, physically and emotionally, but thankfully for all of us, continue to come to work every day to contribute everything they can. And we all need to be incredibly grateful to them. We have learned that we can provide outpatient health care for typical non-COVID disease in many different ways, using virtual modalities, telephones, and electronic messages through electronic medical record systems. And lastly, we've learned that usual healthcare maladies in our communities do not go away during COVID-19, and that delays in these care efforts do have the potential for risk and reality of lesser outcomes. So what am I worried about? In North Central Washington, as Malcolm said, we are now in our third surge of COVID-19. The epidemic curves, as you saw, are nearly straight up. They are exponential. And we don't know where the top is. We had one surge in April, a larger one in August, and now this one is on track to be the largest, to be larger than either of the previous two. The outpatient testing done by Confluence Health in the counties of North Central Washington has had stable qualification criteria since May. So we've basically said if you have you have symptoms, you've been in contact, or you're having a pre-procedure test, we would like to see you get tested. Over the last couple of weeks, we have seen a tripling of our daily phone calls to our COVID triage line. We are now up over 700 calls a day, and 2.5-fold increase in the number of people needing testing daily. The percentage of tests being positive has increased by 3 to 4-fold. Different than the first surge, though, as again Malcolm pointed out, we have seen the ethnic disparities disappear. And fortunately, fewer individuals of an older age are getting sick enough to, and so the younger people are at a lower risk of needing hospitalization. A month ago, our hospital census for COVID-19 was averaging 2 patients or less per day, and as of today is 13 and is continuing to increase day over day. All of these trends are being seen around the state. We are not unique. And this is different than the first 2 surges where there were regional differences around the state. And we need to keep in mind that the need for hospitalization is 2 weeks to 3 weeks lagging the increase in testing positivity. So I am concerned about the ability of our local healthcare system to manage this impending surge of COVID care for a few reasons. The ICU needs for COVID-19 care, for non-COVID-19 care have remained higher than average compared with a year ago, and this continues a trend we have been seeing since May. We can usually staff about 12 to 15 ICU beds without compromising care or safety. The ICU length of stay for COVID patients is typically 2 to 3 weeks, unlike other ICU patients where the length of stay is usually just a few days. Staffing levels at the hospital are lower than where we want them. Some of our nurses, our aides, and our therapists have decided to stop working, and some are taking time away to help with their children's virtual education experience. Recruitment is hard, and demand is way exceeding supply in the nation. Traveling nurses are in short supply because the entire country wants them and needs them. The skilled and critically needed staff providing inpatient care for COVID-19 patients day to day, as I said before, is tired both physically and emotionally. But the need goes on day in and day out with no real end in sight. And I worry about what if the younger infected individuals in our community begin to infect older individuals at higher risk of needing hospitalization or ICU care by visiting those family members in congregate living facilities or getting together with them as family over the holidays. If the inpatient COVID care needs increase, we will quickly reach a crisis point for the reasons above. Central Washington Hospital, with its well-trained and skilled nurses, therapists, and physicians, is the only hospital in North Central Washington to be able to provide care for the sickest patients in this region. Because this trend is occurring all over the state, Other hospitals may not be able to accept patients if we reach our capacity. And at that point, we will not be able to provide usual healthcare services for things like heart attacks, strokes, so on, in our usual way. And we won't treat people the way we would want them to be treated. Skilled staff is our limiting factor. So what can we all do, and what do I ask? Well, we know what works. Masks, hand hygiene, physical distancing, and reducing the duration of interactions. We've got to be diligent with these practices at work, in the community, and at home. This holiday season will be different as we must avoid social gatherings and find new ways to connect with family and friends. My kids are not coming home for Thanksgiving. However, we must act now and engage our community to prevent this overwhelming of the healthcare system, and it will allow us to get our business activity back increasing again and our personal lives back to a more normal. We need to think of everyone not in our usual household as potentially infected. If you develop symptoms with COVID, please get tested and stay away from others until you get the test result. If you test positive, please stay away from others for 10 days or until no fever or 48 hours, whichever is longer. And recognize that all of us in this community, not just the healthcare providers, are tired, stressed, and fearful. Let us give each other some grace and help each other however we can. Because I, no more than anyone, want these next few months to be better than the discussion I've just laid out. However, we need to be proactive in our thinking and our planning so we don't look back and say, I wish I woulda, coulda, shoulda. I would much rather take the blame for being overly cautious and concerned than not concerned enough. And right now, I don't think I'm being overly cautious or dramatic. We're all human, and I think all of us deep in our hearts feel the same way. But finally, let's be optimistic, because we can make a difference. The choices we make individually do matter a lot. We will get through this both sooner and more safely from an individual and a community physical, emotional, and economic health if we all do what we can. We have been doing this, and we can continue. Thank you. And I'll introduce Dr. Mabel Bodell, a nephrologist here in Wenatchee.
I am Dr. Mabel Bodell. I'm a nephrologist at Confluent Health. I'm a kidney doctor. I am not an epidemiologist. I am not an infectious disease doctor. I'm just a physician who is concerned about her community. I'm concerned about our community. Since the start of the COVID pandemic, I was involved in the care of some of the sickest of the patients in our intensive care unit. Their lungs failed. Later on, their kidneys failed. I saw too many of them die from COVID-19. Too many of them look like my father, look like my family members. This pandemic affects our Latinx, Latino, Hispanic community in a disproportionate level because of the place we work. We are essential workers. We were not able to stay home. COVID-19 pushed all the health disparities to the surface. They existed before, but now they are obvious. Despite the fact the proportion of Latinos affected by COVID-19 decreased from 80% to 50%, this is still too high for this region. And perhaps the decrease is because harvest season is over. Our Latinos were and are the most vulnerable ones. If our Latino community succeeds, then our whole community succeeds. A few days ago, we got great news regarding not only one, but two COVID-19 vaccines. Preliminary data suggest that they are 90 and 94% effective. That means that most of the participants on the trials who did not receive the vaccine, they were the ones that they got sick. I'm a proud volunteer of the Pfizer vaccine trial. I trusted the science. Vaccines are some of the safest tools we have in medicine. My husband is also a volunteer. He did have side effects from the vaccine after the second shot. He developed fever, muscle aches, and axillary nodes. This lasted 24 hours. But I would rather get these side effects of the vaccine than the side effects of the long-term side effects of the COVID infection. 1 day of fever versus 1 day being in a breathing machine, so it's really a clear choice. There are still a few more steps to be sure that the vaccine will be safe before it gets approved. Once approved, healthcare workers will be the first one to receive it. But we should not forget our most vulnerable ones in this community. They are also a priority. What is my ask? This is a pandemic like we have never seen before. COVID exists and is everywhere in our community. Please, do not lower your guard. Continue to protect yourself and protect your family. We can go through this, but only if we do it together. Thank you. And now I'm going to do it in Spanish for our Latino community. Yo soy la doctora Mabel Bodel, soy una nefróloga a Confluence Health, soy una doctora de los riñones y como siempre me presento, no soy una epidemióloga, no soy una especialista en enfermedades infecciosas, simplemente soy una doctora que está muy preocupada por su comunidad. Desde el momento que empezó la pandemia, yo he estado involucrada en el cuidado de los pacientes más enfermos en nuestra terapia intensiva. Primero los pulmones fallaron, después los riñones fallaron, y he visto muchos de ellos morir del coronavirus. Muchos de ellos se parecían a mi papá, como mi familia. Esta pandemia ha afectado a nuestra comunidad de forma desproporcionada. Nosotros somos trabajadores esenciales, no pudimos realmente quedarnos en casa. Esto ha empujado todas las disparidades a la superficie. Estas disparidades existieron antes de la pandemia. Y a pesar de que la desproporción de los infectados de COVID ha disminuido de 80% a 50%, esto es todavía muy alto para nuestra comunidad. Tal vez porque simplemente la cosecha ha terminado, pero nuestros latinos estamos los más vulnerables en esta comunidad. Ya tuvimos la noticia que tenemos 2 vacunas que esperan ser aprobadas muy pronto, que son muy efectivas. Y esperamos que esto aparezca muy pronto. Como ustedes saben, yo soy voluntaria de uno de los centros de investigaciones de la vacuna Pfizer. Yo me he aplicado la vacuna y mi marido también. Mi marido ha tenido efectos adversos como fiebre, dolores musculares y también ganglios en la axila que duraron solamente 24 horas. Pero prefiero tener estos efectos adversos de la vacuna y no estar un mes en el hospital en la terapia intensiva en una máquina para respirar. Así que realmente un día de sentirnos mal entre eso y estar un mes en la terapia intensiva es verdaderamente una elección muy clara. Todavía hay muchos lugares para estar aprobando la vacuna, así que cuando se apruebe, los primeros que van a ser vacunados somos los trabajadores en la parte de salud. Pero no debemos olvidarnos que nuestra comunidad latina también es la más vulnerable y tenemos que ser prioridad en el tema de la vacunación. Así que lo que pido es que esta pandemia ha sido como nunca hemos visto anteriormente. El COVID existe y está en todos lados y no quiero que bajen la guardia y que realmente sigan protegiendo a ustedes y a su familia, porque es la única forma que vamos a poder pasar por esto es hacerlo todos juntos. Muchas gracias. Thank you very much.
Dr. Bodell, muchas gracias, and thank you for all the work you and your team are doing at Confluence Health right now in this pandemic. We really appreciate all that they're doing. I'd now like to offer Commissioner Overbay a quick question as he comes up towards the microphone. So over the last now 9 months, Commissioner Overbay has been working very closely with the team at the Health District to deal with all the many challenges that we've seen coming up in the COVID-19 pandemic. We, as the Health District, almost feel like he deserves like an honorary Master's in Public Health degree at this point for all that he's learned and all that he can do as a public health professional at the moment. So our question is, you know, having listened to our good doctors, having listened to our county health officer, what do you see as ways that we should move forward after this evening's presentation?
Well, thank you for the question, Nate. And before I answer the question, first thing I want to do is I want to thank our medical professionals, the leaders in our medical community for the work that they have done through this pandemic. It has been tireless work that they are there on the front lines. I know that Dr. Butler has been juggling multiple things with both patients as well as the stepping up into the position of as our health officer. The other piece I want to do is I want to thank my peer elected officials that are here showing their level of support for this message that we're trying to convey to the community. To answer your question, Nate, where do we go from here? When this pandemic started, we didn't know a lot about it. And there was a lot of information that was coming out, and information today is a lot more rapid than what it was in 1918 with the Spanish flu. And that led to speculation. That led to doubt, that led to confusion, and that led to conspiracy theory. And as that information came out, things changed. And as we learned more, things changed. Yes, mask, no mask. Yes, it's a surface piece. No, it's not a surface piece. And as that was going through, people became confused. And then on top of that, we had an election year, and people decided that this would be a political issue, and they started to create a division in our community and in our nation. And the thing is as we take a look at, as we move forward, this is real. We are at the highest levels we have ever seen in our community since the start of this pandemic. And day in and day out, our men and women are working on the front lines in the medical side, at the health district, the education piece. Public health is about educating the public about how to do things healthy. So where do we go from here? We talk to you, our community, about choices. This comes down to 3 choices. You have a choice to take care of yourself, you have a choice to take care of your family, and you have a choice to take care of your community. When 9/11 occurred, our community came together as well as other communities, and we sent emergency responders and we sent aid to New York City to help the people that we don't even know. When Katrina hit, we did the same thing. We gathered together. We provided aid packages, sent our emergency personnel to another place to assist people we didn't know. When wildfires struck in the last few years across our communities, we reached out to the outlying communities to offer assistance. Even this year with wildfire, we assist Douglas County and their citizens, and Okanagan County and their citizens. These are no different than COVID in the aspect of we need your help. We need you to reach out to this community now. It's here. There's nobody else that's going to come in to help us. We have to help ourselves. So it's about choices. What do you choose to do? You have, I've heard people talk about their constitutional right. It's my constitutional right not to wear a mask. It's not a right. It's a choice. You have, the rights give you the ability to make choices. And what I ask you today is, how will you choose? Will you choose to take care of yourself only? Will you choose to take care of yourself and your family only? or will you choose to take care of yourself, your family, and our community? I think about the upcoming holiday season. Dr. Rutherford, Dr. Butler have both made the comments about the fact that it would be best that we don't gather. It would be best that you stay away from one another right now. Figure out creative ways of being together, whether virtually or otherwise. But we know that there will be those of you who make the choice to get together. And if you do, what we ask you is take all the necessary precautions that are available to you. Utilize public testing that we'll be providing for this coming up weekend prior to the Thanksgiving holiday. Take advantage of that. That way you know before you go that you're safe to gather with your friends and family. So I'm going to leave you with this. Every one of you have an opportunity to make a choice. You can choose yourself, you can choose for your family, or you can choose for your community. My plea to you is that you will choose for all three. Thank you.
Commissioner Overbay, thank you very much for that. So at this time, we'd like to offer our media, who is gathered behind probably what folks can see on camera, to ask some questions of our panel. We have a microphone set up over here. It has the very bright yellow tape on it, so you should be able to find it pretty much in the dark. And if you could introduce yourself and let whoever you're directing the question to know that it's directed towards them.
Hi, Jefferson Robbins with NCW Live. Thanks for having this event. We really appreciate it. Today I was passing North Wenatchee Avenue, saw a small group of gentlemen who were obviously without shelter, gathering together very closely, sharing conversation, cigarettes, whatever resources they could spare to each other. No masks. I wondered if somebody with this outreach, with this effort, could talk about what outreach, what resources are available to those folks who are living without shelter, who may be at risk of exposure, or worse yet, may be positive for COVID-19. I know there's a few out there, but I wondered if somebody could provide a laundry list for those watching and listening.
Who would like this? Sure, I could start this. So with anyone in our community who we believe needs to be tested for COVID, we have options for getting those tests. We have certainly the opportunity, if you believe you've been exposed or that you are ill or that you're going to have a medical procedure, to go up to Confluence and be tested there. We're also in the process, and of course I left my address on the table, of setting up some community-wide testing again this week and into the first of the year. So we will have a number of ways to get tested. If anyone is positive for COVID-19, we really do work very closely with that person and other community organizations to make sure that that person can safely isolate if they're ill or quarantine if they're a contact to that ill person. We have, at this point, mostly managed to find people a way that they can safely isolate or quarantine at home, at a friend's, at a cabin, at a something. But we do also work very closely with Serve Wenatchee, who has very generously helped us work out some arrangements with hotels, and we've had some folks that have quarantined and isolated in that setting as well. In that, we also work with Serve Wenatchee to make sure that we can provide the right wraparound services to people who are being isolated and quarantined. It's difficult, it's hard when you're being asked by your community to stay in your home for up to 14 days. For some folks, that's a very significant challenge. And we know that they need some support with food and with other things. And so Serve Wenatchee, again, has really stepped forward to help us provide that to our community. And as a backup to that, we also work with our state health department, who's developed what they're calling a care coordination strategy, which allows us even more capability to reach some folks that maybe we're not able to reach with some of our local resources, to make sure that they can also isolate and quarantine safely. So anyone in this community, no matter their living situation, if they feel like they've been exposed or they are positive for COVID, then we will work with them and others to make sure that they have a place where we can safely isolate and quarantine. Thanks for that question.
I guess I would just mention that I know over the last several months, hundreds of thousands of masks have been distributed. They've been taken out to the support agencies around town. And I would say if anybody needs a mask, there are plenty of masks. You could come to my clinic, you could go to Confluence, you could basically go to any clinic you want, and at the front door you can ask for a mask. You can go to a fire station, you can more or less probably go to almost retail establishment, any retail establishment in town and get a mask. So they're readily available all over the place. Thank you, Jefferson.
And on that note, I was able to actually grab my, my sheet here. So we will have free testing, the drive-through style testing at Kashmir High School, which is at 329 Tigner Road from November 19th from 3 p.m. to 7 p.m. and on November 20th from 10 a.m. to 2 p.m. We'll also have testing at Wenatchee High School, which is at 1101 Millardale Avenue on November 21st, 22nd, 25th, 27th, 28th, 29th, and 30th, and the times are from 9 in the morning until 4 in the afternoon. So, thank you.
Hi, Kyle Lamb, News Radio 560 KPQ. I have one question for Dr. Butler, then one for Dr. Rutherford. My first question is for Dr. Butler. So, as we've seen repeatedly through this pandemic, outbreaks have been following major holidays. Have health officials attempted to determine what infection rates could look like numerically in our area following the Thanksgiving holiday?
Yeah, so it's an interesting question. Have we tried to do any modeling as to what things could look like? I would say locally we have not tried to do that. There are groups that are doing a lot of modeling, and it turns out the University of Washington happens to be a leader in the nation in that. And what I can tell you, again, this is a pandemic which is rolling out real time. I mean, we don't have a lot of time for people to survey everybody who gets sick and then try and predict what's going to happen, you know, if we go forward. So the simple answer is no. But I think also when we look at what has happened after Halloween, we did see a dramatic increase. I don't think we can say that that dramatic increase was only related to Halloween, but certainly it looks suspicious. And I think all of us are very, very concerned about Thanksgiving. Because if one evening of kids getting together and families sharing a good time on Halloween can lead to what we've seen over the last couple of weeks, it really frightens me to think about what 4 days of families getting together and sharing time together could do.
Thank you. Mm-hmm. So my second question, again, for Dr. Rutherford, although perhaps Dr. Butler could answer this as well. We've seen in other regions hospitals reach and sometimes exceed capacity during this outbreak. How many hospitalizations exactly would constitute capacity for our two-county area? And with the current case rate at 686 per 100,000 over 14 days as of this morning, and now 13, as you said, hospitalizations, where do you think the case rate would need to be for our region to reach capacity? Thank you.
So I think that's a bit of a hard question to answer, but I'll try to give you some perspective. So as at Central Washington Hospital, well, let me back up. When people are hospitalized with COVID-19, they are either hospitalized and may need IV fluids, may need anticoagulants, may need oxygen. And those patients can be managed in a traditional hospital bed. If people get worse than that and need a nasal oxygen or an oxygen mask or other things don't do the job and they need to be put on a ventilator, then they need ICU care. In the first outbreak of this, or first surge back in April, the ratio in our hospital was about 2/3 of the people who were admitted needed ICU care and 1/3 did not. Now there have been many changes in the treatment and things like what Dr. Bodell spoke to, that the ratio right now is probably reversed. It's probably 75% are in the regular hospital beds and 25% are in the ICU. Many of the patients who just need oxygen, anticoagulants, IV fluids can be taken care of in other hospitals in this region if we need to, but it really is, for many of these people, nice to have the pulmonary doctor, the nephrologist, and so on available, and that focuses it in Wenatchee. What we don't know is what's the correlation between the current case rate and when is that population going to reflect the hospitalizations. Because what we're really seeing is the hospitalization rate at this moment based on the infection rate 2 or 3 weeks ago. And at that time, the rate was probably half what it is now. The other issue is, so Central Washington Hospital can relatively, with not much, or with a little bit of stretch, staff about 15 ICU beds. With a change in how we staff and reducing surgeries and closing GI labs and closing physical therapy, because of the number of people that this takes to take care of these individuals, we can probably get that number up into the low to mid-20s. But that will be when we are starting to compromise care, because it won't be an ICU nurse for every patient. It'll be an ICU nurse overseeing 2 other nurses helping patients. And we really don't want to go there, because we can't then assure that we are doing the absolute best we can for every patient. So I am nervous at 600 what it's going to look like in 2 weeks from what's infected right now. And that's the concern. The other piece is, I say that ICU capacity, but remember that there's a whole bunch of other stuff still going on in this community that needs ICU care. People with heart attacks, people with strokes, people who need large life-saving surgeries and need ICU care. And that number is higher right now and has continued to be higher than 1 year ago for reasons that are probably related to the delays in care in some degree from the pandemic shutdown that we had last April. And we're still living through that. You have any, Malcolm?
I'd follow up with a question for Dr. Bodell, if I could. And you mentioned the rather outrageous impact on the Latinx community that this disease has had, and how it's brought some disparities to the surface that were always there all along. Do you feel like part of the reason that the proportions have shifted a little in one of the graphs that Dr. Butler showed is because of outreach and because of education and attempts that have been made to sort of bridge language gaps or culture gaps? Do you have any insight on that?
I think that the proportion definitely improved partially because of that, but also what I mentioned before, what we call the social determinants of health. And I think that the harvest season ending, that decreased exponentially the exposure of the agricultural workers. So, and that really changed dramatically recently. So I believe that that could be a big component of the proportion. So, but as you said, yes, we are definitely working very hard with the outreach in so many grassroots organizations, as well as the Chelan and Douglas Health District, to really reach and really try to get every single member of the Latino community the information that they need to make the right decision. But the CDC was here, and actually the numbers of the Latino household following all the guidelines is actually very high. So they're getting the information and the following. So, but it's some things that we cannot change. So as I said before, the place that we work, the place that we live, these things are not changing.
And I think that you are among the first health professionals to do online outreach in Spanish that I saw. So you're to be commended for that, I think. I have another question for those folks directly involved with the health district, board members, health officer, administrator. As this pandemic unfolded, we saw the health district in something of its own crisis. We saw individual board members taking issue with health restrictions that have been put in place at the state level, even to the point of filing lawsuits. We saw some fracturing on the board. We saw changes in administration. Mr. Weed, you're the third administrator since this pandemic broke out. You're an interim administrator, and the search is still on for a permanent administrator. Can the public now feel confident that this health district and this board and its leadership is on the same page and moving forward to address this crisis and has resolved its internal disputes?
Yeah, thank you for that question. That's actually a very insightful question. I'll at least take an initial piece, and then Commissioner Overbay, maybe you'd like to take it again. But certainly the Chelan and Douglas Health District has faced a lot of challenges, and it was facing challenges prior to the COVID-19 pandemic. Across the nation, across the state, we have seen a number of local health jurisdictions struggle mightily under the weight of the COVID pandemic. It is hard to really express sort of the change from day-to-day business in a local health department from what it looked like prior to the pandemic to what it looks like during the pandemic. Most health departments and most health districts, they are run on a very minimal margin. Typically, there is some local tax dollars that go into it, and then a number of grant-funded programs that balance it out. This does not provide a great deal of resilience in how the workforce in a health district can be employed. As this COVID pandemic took off, local health jurisdictions were primarily responsible for the initial public health work. And to give a sense of the initial public health work, the first thing is really the ability to communicate to the public, right? And our ability to let the public know that A, there is a risk, and B, what they can do to protect themselves and their family in that risk. The second thing is really our epidemiologic and surveillance work. That all starts and ends at the local level. So our ability to quickly mobilize a surveillance system for a disease that we'd never even heard of before that's an enormous task. Then, once we have that established, we also have to figure out how we can get people into that surveillance system, and that is through testing in most cases. So for a disease that we did not have a test for, that we did not have any sense of even necessarily what we would do to test for it initially, to the point now where we're talking about at least 2 drive-through testing options and the testing site at Confluence, that's a huge evolution. And to get there required many more people than really actually the Chelan and Douglas Health District employs. Finally, once we have that, I mentioned the isolation and quarantine. That's a huge effort. Isolating one person is often the most a health district can do. And in many counties across, not just Washington, but across the nation, if they have a person with, let's say, multi-drug resistant tuberculosis and need to quarantine that person, often they use their jail. That's the only real option that they have available to them. And the health officer usually writes an order, and that person spends actually quite a bit of time in jail as they work through their therapy. So to mobilize the kind of resources necessary to do all of that in this pandemic with a small health department of around 40 people, that's not a thing that's easy to do. The other piece is that in the way that health funding is allocated to local health departments, there's a trend. And I think this is a trend where we see health districts that serve about 100,000 people are often some of the most challenged financially. And the reason is that with 100,000 people living in one area, you really do have to have a full-service health district. But the funding available to that size of a health district is not sufficient to have a full-service health district. And so there's this struggle where we try to optimize the staffing patterns as much as we can to be able to do that work. So for Chelan and Douglas Health District, which was already suffering from that experience, and many, many years of cutbacks since 2010, this COVID pandemic really did create a situation in which folks made some different choices about really whether or not this was what they were going to spend their energies and efforts doing. So yeah, there's been some turnover in the leadership positions at the health district. I have been invited here to help kind of get things on an even keel as we move through the pandemic. I feel that we've actually created a very solid capability in our newly forming COVID division, which is, it's not a big number of people, but it is at least 6 extra bodies that are focused solely on COVID. We've also done a little bit of adjusting where Alma Castillo, who's right behind you, she had, I think, 3 different jobs that she did generally. We've peeled those additional jobs away from her workload and given those to some other folks and really asked her to be our primary outreach coordinator. So we've done a few things internally to optimize our capability to continue the response to the pandemic. It will not be easy. It's going to be really hard. These things do not stop, they do not slow down. So for this health district to maintain that success, it's going to be tough over the next several months. And it's going to be tough for every local health jurisdiction in this country to keep that pace for the next couple of months. So I would say, yeah, I feel like this health district has come up on a nice even plane. They're able to do what needs to get done right now, and it's really going to take the community supporting them and working together with them to really continue that success on into the rest of this pandemic. So, Commissioner?
Yeah, thanks for the question, Jefferson. As about halfway through this piece, around the June-July time, we did have a board leadership change. And so Dan Sutton became the chair of the board, and I became the vice chair of the board. And Dan and I sat down and had a conversation, and the board basically gave us the latitude to go ahead and work with the Department of Health, with our local health officer, to kind of turn things around a little bit and take a look at what is it that is the immediate need. And the one thing that we looked at was the fact that our staff at that time had been working for, since the beginning of the pandemic, and they had been doing the incident management. And so we recognized the first thing to do is we needed to allow that staff to be able to take that break, but also there were other health department related items that we had to take care of. It wasn't just about COVID. There were other things that still needed to be taken care of, the routine pieces. And so we were able to work with the Department of Health, with Secretary Weisman and Dr. Lofi. They basically gave us Nate on loan, and we took advantage of the opportunity to have somebody that had public health experience. We had, of course, put Bruce Buckles into the position, because of the departure of Barry Kling, and we needed to make sure that we had somebody who could come into that and work with Dr. Butler at the beginning so that there was not a gap. And Bruce graciously stepped up and said, I'll take on that role, even though he was still running another organization with aging and adult care. But he did that. And as we worked through the process, we saw an opportunity to be able to utilize expertise and bring in Nate, which we did do that, and basically had an opportunity to work hand in hand. We meet with the Department of Health every other week in conversation. We meet with the governor's office on the off week, and basically we have been in contact with them, in conversation with them from that point on. We have a vision for the health district. We actually created, as a part of the review process that was done by the state epidemiologist that came in, we put together a coordinated policy group, and that group initially was meeting almost daily. When it first came about, we went down to 2 days a week. We now have a functionality of 1 day a week right now that we're currently doing. And basically that group represents business, the Latino community, it represents the government side of things and the medical side of things. And we come together and we are looking at the strategies that we are going to implement as we move forward to take care of this virus. So I would say that we are on a great trajectory. We are in the about the middle phases right now of looking at candidates for the permanent position, and that will probably be selected within the next couple of weeks. That individual will be, and be able to have hopefully a little bit of time with Nate for the turnaround. There are still some gaps in that, but the citizens of Chelan and Douglas County can rest assured that the health district is in good hands. We have a great working relationship. Our health officer, the staff, and the board, we're all on one, basically plane. We all have the same goal in mind, and that's to actually make this a functional health district that this community could be proud of and that this community can utilize for its public health needs in the future.
Hello, my name is Rafael Aguilar. I'm with Per Media, La Pera Radio, Spanish radio. We are online radio, and I've been here in 6 years in the city of Wenatchee, in East Wenatchee. It's good to see the city representatives, mayors, county. This is what we need, and of course, the local media work together. I also want to commend Dr. Mabel and the district representatives. They work on a daily basis to provide information for us, the Spanish media also, and I'm proud to be here today. I have a question for Dr. Mabel Bodell. We're very excited that Halloween is over. Now I'm worried that Thanksgiving is coming. But I'm not only worried about Thanksgiving, I'm worried about Christmas, I'm worried about New Year's. In the Hispanic community, January 6th is a bigger festivity than Christmas for Mexico and other Latin American countries. We don't have Santa Claus in Mexico. We have the Tres Reyes. So the kids get the gifts on January 6th. So for us, we celebrate Christmas and we celebrate January 6th. How ready are we to receive all these festivities if with Halloween we have a little bit of a increase of cases? And we're going to have Christmas, we're going to have New Year's, and we're going to have Dia de los Reyes in Spanish, the Three Wise Men celebration. How ready are we for those three big fiestas coming up? Are we ready? Or what would you like to see all of us do as a team so that we can tackle that next challenge? I'll like to see if we can do that in Spanish too. Me gustaría preguntarle a la doctora. En nuestra comunidad hispana celebramos la Navidad, pero también celebramos el Día de los Reyes, el 6 de enero. So vienen tres fiestas grandes. Viene la Día de Acción de Gracias, que la hemos adoptado, la Navidad, el Año Nuevo y el Día de los Reyes. Son cuatro fiestas grandes, las más grandes del año. The biggest celebration of the year, four big celebrations. ¿Estamos listos para tratar de encontrar una prevención de más contagios? ¿Y qué le gustaría que hiciéramos nosotros como medios de comunicación, como entidades de la medicina, de los hospitales y los alcaldes que están aquí comisionados trabajando juntos? ¿Qué le gustaría ver a usted, doctora, para ayudar a prevenir más contagios en las próximas fiestas? Gracias.
Well, Rafael, as we spoke over the radio the last week, so definitely we can't really take any risk at all. And as we said before, despite the fact that all these big festivities are coming, and as you said, Reyes, so the Three Wise Men is going to be very big for our Latino community, we can't really spend time outside our family. So really nobody else that lives really in the same household, which is going to be almost impossible to even think about doing that. But as we spoke the last few days, Rafael, that would be the only way that we can stop this. So como hablamos en la radio el otro día, Rafael, el martes, que realmente tenemos que no tomar ningún riesgo. O sea, la curva que estamos viendo está subiendo exponencialmente. O sea, no podemos pasar tiempo con alguien que no vive con nosotros en la misma casa. No podemos tomar otra vez ningún tipo de riesgo. Así que obviamente enfatizar, como estamos haciendo los últimos días, en realmente cambiar de planes para todas estas fiestas. O sea, realmente es triste, pero tenemos que tomar conciencia y protegernos, proteger a la familia, porque va a ser la única forma de que tengamos la familia para el próximo año. Así que gracias, Rafael, por la pregunta.
I'm Oscar Rodriguez from the Wenatchee World. My question is for Dr. Butler. During your presentation, you go over a lot of the statistics and the data, but for some of us in the Valley that perhaps aren't so data-driven, data inclined, could you, express in your own words, the seriousness and the direness of the situation in words other than, data?
Yeah, thank you. I have personally been fortunate to get to know and work with Dr. Peter Houck. It turns out that Dr. Peter Houck actually grew up and went to high school here in the Valley with Dr. Peter Rutherford. So we need to refer to them now as Peter H. and Peter R. Dr. Peter Houck grew up and went to medical school and then entered public health. And he spent his career at the CDC. He became one of their investigators and spent most of his career fighting epidemics, fighting pandemics, fighting things like Ebola and bird flu, and has worked all over the world doing those things. And he retired a few years ago, and we were lucky enough to have him come and join us out of retirement. Yesterday, Peter Hauck told me that he has never been as scared as he is now. So you have a physician who has spent his entire career fighting pandemics around the world, who has never been as scared as he is now. Does that answer your question?
Kyle Lamb, KPQ again. My question's for Dr. Butler. Come back on up there, sorry. So many of those skeptical of COVID-19's physical impact to our population have pointed to mortality rates. What is the mortality rate currently for COVID-19 in our region? How does that compare nationally? And is mortality rate an accurate metric to use to express the severity of this disease?
Yeah, interesting. You know, I actually don't know what the mortality rate is right now. I don't know what it is locally. Because to a degree that's evolving. You know, what it was last month is different than what it is now. And the mortality rate depends a lot on how old you are when you contract it. It appears also that the amount of virus that you inhale is important. Dr. Rutherford pointed out that if you are wearing a mask, you're likely to get a less severe case than if you're not. And what we know about, for example, emergency room workers early in the pandemic who were seeing many, many people all day long and inhaling gobs of virus ended up getting much, much sicker than people who perhaps had only spent, you know, an hour in a car with somebody who was positive. So what I want to point out, though, is it's an interesting question. Is mortality rate important? And why do we fuss about mortality rate? To put this in perspective, the 9/11 tragedy, in this country, we lost about 3,500 people. What's happening today across this country is equivalent to 2 9/11s every single week. When we have 1,000 to 1,500 people a day in the country dying from COVID, that's equivalent to 2 747s crashing into each other and going down in flames with all hands lost every single day. And so again, for those of us who are in healthcare and spend our time, and it's not just that, it's Dr. Bodell watching a person in the ICU dying of COVID and their family is not allowed inside the room. So the tragedy, unfortunately, is sort of beyond my personal comprehension. And again, I think it's easy. I've heard the argument, well, gosh, everybody who's dying is about 80 years old, right? Okay. Well, isn't that the average age of death anyway in this country? Well, yeah, it is, but what about the people who have, you know, I mean, the average age of death in this country is 80 because we have some people who die when they're 30, 40, or 50. We have some people who take incredible care of themselves throughout their whole life and they're hoping to live to be 100. And this thing is just going to tag you and take you down no matter how you've lived your life. And the families of the people who have been affected have been devastated. And until I think you know one of those people or it's somebody in your family, it's hard to appreciate the impact of that. Another thing, even if the mortality rate, I mean, the mortality rate is ridiculously high, right? Way higher than influenza. But what people aren't picking up on is the fact that about 2/3 of people who contract COVID will continue to have symptoms 3 months later. So 3 months later, you've still got bad headaches, you still feel tired, you've still got a cough. 3 months. When we look at the hearts of people who are sick enough to get hospitalized, so if we take an ultrasound machine and look at their heart, 60% of people have heart damage. And that heart damage is they're going to carry that with them for the rest of their life. So, I mean, we can look at death as a measure of the severity of this, but that's a late indicator. I mean, it's tragic and devastating, and I can't believe how bad it is. But what we call morbidity associated with this, the downstream impact, the fact that you used to be a star athlete and you don't get to do that anymore, that's what nobody's talking about. And again, you know, I mean, I know that there are people out there who are not in the business of saving lives, who think that this is all theater and drama. But until you've been in that position, you won't think about safety the same way we do. The reason that airplanes fly safely across this country is because safety is job one. And nobody thinks about getting on an airplane. But if we told you that we're going to put 3 times as many people as normally sit in that airplane, and then fly you through a snowstorm to Chicago, people are going to get worried. And so, yeah, the hospital's got capacity right now. You don't want to see it at twice capacity flying through a snowstorm when you get appendicitis or when you have a stroke. You want the hospital to be fully functional and ready to receive you after your automobile accident or your snowmobile accident, or if you even cut your hand open in the kitchen. You want to be able to get into the emergency department and get sutured up. And if there's a line out the door because we don't have the staff and we don't have the bed space, it's going to be a bummer. So the mortality rate, I think, is one thing. But for those of us who are working with this right now, it's not tremendously important. What's important are, as Commissioner Overbay said so nicely, it is the individual choices that each of us are making. I have spoken to people in this community, and they have told me, it's not my job to worry about anybody else. It's my job to worry about myself and worry about my family. And I got to tell you, I disagree. And I think Commissioner Overbay disagrees. It is our job to worry about our neighbors and to do whatever we can to keep our community safe and healthy. Thank you for the question.
I'll ask one more for Dr. Rutherford, if I may. Talking with you in the past, I know you've been very proud of the people who work for you at Confluence Health. And from your earlier statement, it sounds like some of those people have been overwhelmed and have decided to do other things with their careers. Can you give a perspective on about how many of your staffers you have said goodbye to, and how easy or how difficult will it be to plug the gaps that they leave?
So currently at Central Washington Hospital, we have somewhere, I believe, around 60 RN openings. And we have openings for about 30 nursing assistants. We are hopeful that some of the people who have decided to take time away at some point when the pandemic passes, will be willing or wishing to return to work, and we will welcome them as we can. The ability to recruit is very difficult right now. The Wenatchee Valley College has a very nice nursing program, but they're not at a point of graduating anybody. There is one at Big Bend College in Moses Lake. They're in the same cycle. Our housing prices here in Wenatchee and this area are getting to the point where it is too expensive for nurses to be able to afford to live here. And so they will choose to live somewhere else. I think our best hope is going to be recruiting and people who live in this valley and choose to get trained and choose to get experience and then choose to come to work. But that's a years-long process.
Thank you all so much for coming out this evening and sharing with everyone your experiences, thoughts, and wishes for the future with this COVID-19 pandemic. I want to thank NWC Life so much for helping us pull this together, and for LocalTel for providing this forum for us tonight. Also want to thank all of our mayors and council people who came out this evening as part of this effort. I'd also like to finally just thank the staff of the Health District and our Joint Information Center for the work that you did to help organize all of this and find speakers and make sure that we were well prepared for this evening. Thank you all so much. Please travel safely this evening, and we wish you all to be well. Thank you.